Hello and welcome to episode 24 of 4D version 2. This is a detailed discussion and dialogues for Indian diabetes. Today's episode, we will be covering uh, again a very important topic, which is CVD risk and body weight. And for today's episode, which is extremely important, we have today with us Dr. Shivani. She is an assistant professor at AIMS Batinda, and she's an assistant professor in the Department of Endocrinology. She has a lot of interest in dealing with young diabetes, mineral and bone density diseases in endocrinology. She has more than 30 publications to her name in national as well as international journals. She has won grant awards in the year 2018 from ESI, and she's also had got a best poster presentation in the 49th annual ESI conference. So, Dr. Shivani is the right person to walk us through this wonderful topic. Over to you, madam.
Thank you, sir. Thank you for such a nice introduction. So today we are going to discuss the body weight, which is a risk factor for both diabetes and cardiovascular diseases. We know obesity is growing epidemic worldwide, and as Indians are more prone to develop metabolic complication of obesity at even lower BMI. So it is a complex condition of increased subcutaneous and visceral adiposity. So associated with the adipose dysfunction. Obesity is basically associated with the adiposopathy. So it is basically adipose tissue dysfunction, and that it means that the adipose tissue distribution and function is not proper. It is not just increase in the body fat, but it is the adiposopathy that leads to complications like insulin resistance that increase the risk of diabetes and cardiovascular disease. In If we talk about prevalence in urban Indians, almost 3 out of 4 Indians are overweight, and prevalence of abdominal obesity was found to be 40% in women and 12% in men. And studies have shown that 5 to 6 out of 10 women between the age of 30 to 49 are abdominally obese. And the association of abdominal obesity in women is stronger with the increasing age and in the wealthier sections. So, Indians are known to have the highest cardiovascular complications, and the prevalence of CAD in Indians with diabetes is 21.4%, and those in without diabetes is 11%. And prevalence of CAD is higher in the urban part as compared to the rural part that we will discuss later on. And if we talk about diabetes, India is the diabetic capital of the world, and around 77 million people above the age of 18 are suffering from type 2 diabetes, and nearly 25 millions are pre-diabetes. So there is huge burden of diabetes and pre-diabetes in Indians. And adult, as we know, the diabetes are more prone to have cardiovascular diseases and also cerebrovascular diseases as compared to the normal healthy subjects. So, is there any link between obesity, diabetes, and cardiovascular diseases? Yes, there is definitive link between the three entities, and it has been proved by the this UK Biobank cohort study, in which it has been clearly found that with the increasing BMI, there is increasing incidence of cardiovascular disease even across the spectrum of population without diabetes as well as with diabetes. So why it occurs? Because in the patient who have adiposity, there is increased adiposity. There is release of free fatty acids that leads to lipotoxicity. This lipotoxicity leads to defective mitochondrial functions and increased reactive oxygen species. All these contributes to increased insulin resistance. This increased insulin resistance through various pathways leads to, especially in MAP kinase pathways, leads to accelerated atherosclerosis even without diabetes, and it leads to activation of impaired PI3 kinase pathways that lead to development of diabetes. So to prevent these, we have to make the environment, uh, our internal environment healthy. For these, to prevent the obesity, we have to limit our unhealthy food intake. Basically, to prevent obesity, type 2 diabetes, and CVD, we have to take the preventive measures which are common to all these. So, we have to take healthy foods, we have to increase our physical activity, we have to limit our screen time, and of course, sleep quality and sleep time is important. And if the patient develops diabetes, then the dietary restrictions are even more. And if the patient develops, to prevent the CVD, then we have to take care of both obesity, diabetes, and other risk factors like dyslipidemia, to check the blood pressures. So, prevention is the key. But if the patient has obesity or diabetes, then we have to treat the condition, and the best therapeutic measures are lifestyle modification along with the new drugs that help to reduce the weight. Even for the patient without diabetes, we have limited number of drugs available, and the we in India mostly we have orlistat, and however newer drugs like liraglutide, semaglutide are also showing the promising results. While those who have diabetes, the newer drugs like SGLT2 inhibitors and GLP-1 receptor agonists have shown to decrease the body weight that leads to significant improvement in the metabolic health. So, besides preventing the progression of diabetes, they and treatment of and glycemic control, these drugs help to improve the complication, especially the heart failure with the heart failure. Both effect of SGLT2 for the treatment of type 2 diabetes in the patient with and without with heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, it has been seen that they have significant uh, decrease in the hospitalization with the heart failures in these patients. So they are in. It has been proved by 24-week in multi-center randomized double-blind control trial, and with the use of SGLT2 inhibitors. In this study, they have used dapagliflozin over 20 uh, over baseline over 24 and 8 weeks. They have shown significant reduction in the body weight and systolic blood pressure with after the use of dapagliflozin, besides improvement in glycemic parameters like HbA1c, fasting, and postprandial blood glucose. So, and if we combine SGLT2 inhibitor with DPP4 inhibitors, then the effect is additive. So, basically, SGLT2 inhibitor decreases the body weight, and they cause glucosuria. They improve the uh, because of the reduction in the weight, there is decrease in the insulin resistance. And while the DPP4 have different mechanism of action, they have effect on the incretins. So the pathophysiologically they are targeting the different pathophysiology of diabetes. So they have additive effect. As we have seen that if we hit the target early, then if you hit the disease early and achieve the target early, then there is a better outcome later on because of the memory effect, because of the legacy. It's known as legacy effect. So, combination therapy will lead to better improvement in the glycemia early and rapid achievement of this normoglycemia and reduction in the body weight have better long term outcomes. So they have better BP reduction. Even it reduce the pill burden. It make the patient more compliant, and of course, economy is saved with this combination.
Thank you so much, Dr. Shivani, for walking us through these important steps when it comes to dealing with the link between obesity and diabetes. Before I start, let's look at a couple of special group population, especially when we talk about tackling obesity in children. um, it becomes a challenge, first of all, because most of the time, because the children are active, they're healthy, Only when they fall sick, they'll meet the pediatrician, and then some discussion will happen. But now we are starting to see acanthosis, and signs of insulin resistance in these young kids. How often are you now picking up, seeing these early pre-diabetes, early diabetes in type 2 diabetes in these subpopulation? What are you finding in your practice, madam?
Actually, I think this situation is becoming very alarming these days. And I would like to share a case of a 14-year-old child who came to OPD. She was basically having single parent, so they were used to take daily. Their meal pattern is they call the food from outside only. So because economy was not issue, so she developed type 2 diabetes at such a younger age, at 14 year of age. So I think this. And another story is that in one day I came across three patients. All of three were IT professionals, and all of three have developed diabetes at the age of between 20 to 25, type 2 diabetes. Why? Because of their sedentary work behavior, and they are doing work all the time from home, and from the computer they are doing work. And because of their sedentary lifestyle, they are taking, along with the to decrease their boredom, they are taking the cold drinks and chips all the time while doing the work. So the unhealthy lifestyles is, I think, becoming so much incorporating in our life that it is taking our health away, even in the educated population, not even only in the lower socioeconomic group, but even in the patient person who are highly educated. So it is the figures are alarming, I think, these days. Even at the
Yes,
younger age, they are developing complications.
I'll give you an example of a rural clinic where I work in. It's around 40 kilometers from Bangalore. The number of obesity individuals, dealing with obesity in rural India is also exploding, and I would attribute it to the kind of see here in if you talk about in the cities, it will easily put the blame on physical inactivity and junk food. But even in the rural India, we are dealing with individuals who are taking diabetes when there's dealing with diabetes and obesity. It is purely because the kind of food that is available. So they just stick to the carbs, and there is no balance in their meals. The level of physical activity has come down because of slight amount of modernization that we have in the villages. So I think it is like equally both rural as well as urban. We need to be proactive when it comes to dealing with these cases. Now let's look at a little bit about managing the obesity. I think to start this conversation, usually if individual is coming for diabetes, suddenly now if the doctor is saying you need to we need to manage the obesity, they'll get suddenly they get shocked. They'll be like, what, when I've come for diabetes, I've come for thyroid, why is this doctor talking about obesity? And so they kind of are not understanding the seriousness of why we are looking to manage diabetes. I think we need to have a stepwise approach when we broach the topic to our patients. How have you found the behavior or receptiveness when you're saying talking about therapies or lifestyle? What do you think is your the receptiveness and the seriousness when we are talking about obesity management?
Actually, in my initial days of practice, I used to say that you have to reduce the weight and all. But now I used to say, whether you want to get cured with the diabetes and whether you want to get remission from diabetes, then the person say yes. Then I say, oh, there is only one choice. You have to reduce this much amount of weight in this much period of time. So if you are able to achieve this target, then you can be then there are 70 to 80% chance that you will be free from the pills if it is recently onset diabetes and the person is obese. So I give them targets according to the body weight. Around 10% of body weight you have to reduce in next 6 months. If the patient is very young, then I say next 3 to 4 months. You put it on the chart, you put it in your room. So you have to achieve this target if you want to be free from your medicines. So by this approach, I think patients are becoming more receptive to the advice that yeah, I want to reduce these pills, I don't want to take medicine, so please, uh, I will do
Well,
whatever you will say. So by this, and I also take the opportunity to uh, their attendance, that if you are also their relatives, you are also prone to get these complications. So all of you have to take the measures to prevent the complication in future. So not only the patient, so it will, and home environment will definitely help the both the patient and the other ones. So I think this approach is working these days for me.
and so now GLP-1, use of GLP-1 now, thankfully, liraglutide has come to a, to a lower cost generic. So we have some lesser costing alternatives that are there. But if you look at the the maximum number of other molecules that we have with GLP-1, it kind of becomes a very select group of people which we can
Mhm.
use GLP-1. uh, and especially when you talk in diabetes, SGLT2, we all have been using, quite a lot now to help us achieve our not only diabetes as well as weight loss targets. So combination of these two, GLP-1 as well as SGLT2, right in the beginning, so that we are able to achieve that weight loss goal, as well as when you talk about glycemic legacy. So when you're using these two molecules, you're combining all you're targeting these other pathophysiologies, and you're able to approach diabetes much more better. We're achieving the weight reduction. So do you feel the way forward is using go all out? It is not, you're not just going step by step like how we used to do before. So go all out right from the start. Do you think it makes a difference?
I think but earlier we achieve the weight loss more better is for the patient. So the if wherever we can use this combination of the drugs, that is well and good. But this also doesn't fit in each and every patient, because some patients are very reluctant to take drugs. So in those we start with the one drug and then add on in the next visit. So but those who are highly motivated, and I think the combination approach to start with is the best, because when the patient get the result early, so there are more chances to get to maintain it for the long term. So I think combination, if we can start early, is best. But if we can't start early, then also we make the patient, sensitize the patient in the first visit, that we are going to add it in the next visit if we are not able to achieve this much of weight loss in this much period of time. So it's
Making a
good to
plan,
start.
letting them know, hitting those targets, then up titrating if required. So I think it makes sense rather than overwhelming. Some people are motivated, some are not. So we have to definitely see what the patient also needs. I think we can't always force our thought process on the patient, because sometimes patient will there will be a pushback saying that look, this is overwhelming. And sometimes you can't do everything in one visit, especially when you talk about obesity management. There's a lot that goes into taking a proper diet recall history, see how they're hitting their targets. Mental state of mind is also very important. So how do you how are you able to do so much in your whatever little time that you have with your patients?
Actually, diet review, you have sir has taken this initiative, that it is diet review is very my favorite part. So because in busy OPD I can't take history at all in such a short period of time. So I used to ask the patient to I give them paper and pen, and I used to ask the patient to write down whatever you have eaten in last 24 hours and in the last weekend. So I have observed many of patient doesn't know these bakery products like biscuits and all. They are uh,
Excluding.
they have so much of
Yeah.
carb content and calories. So they are
Yeah.
taking it like snacks that doesn't cause any impact on their blood sugar. That doesn't cut any impact on their weight. So by dietary recall, it is
Yeah.
easier to explain them that these things are the ones you have to completely exclude from diet, then only you can achieve your
Definitely.
targets.
I,
So dietary
I
recall is
very
very good
important.
method.
And I've taken an approach where we just take food photographs. So they'll keep it in their so if they're coming for a visit, so they're taking regularly some food photographs. I make them become like a food blogger for a 1 week before their visit. And I also tell them, check your pre-meal and post-meal levels also when you're eating certain foods. By
That's
doing
also
so,
good.
they get an understanding, so they are also very much involved in their management, as well as they get to realize. And what I've realized, when we talk with the data points of them, like rather than generic data points, so I'm telling them, eat, do this, do that, they will not. When I talk about them, they tend to be more receptive. And when they see their own plate, when they see their own glucose numbers which is with that food, then they start to realize, okay, this doctor is telling correctly. When we say don't eat biscuit, why we don't want to tell you to eat that biscuit before that chai? They'll eat one full biscuit packet, and then they'll expect that the pre-breakfast has gone up already. Starting off their fasting is very nice. They'll eat that full packet biscuit, then pre-breakfast it is gone from 100, it has gone to 200, and then post breakfast it is 300. So then they're like, I'm eating very little breakfast, I'm eating very little breakfast. So
Yeah,
we have to put that time,
dietary
I
recall.
guess. Yes, and if you don't, I think it is important that if you have a very very busy practice, it is important that you have a team also to help us manage. So these are important steps when when we are looking at taking the help of technology. All of that helps, and now we have so much of options. I think when it comes, it not like how it was 20 years, 30 years. We have the molecules are there to help us to achieve these targets. I think we're doing great with how things are going. And the more and more we are developing these newer molecules, next year we will have the GLP GIP also will be into our Indian market. And so it makes a big difference. And I think these newer drugs also make are going to change the way we approach. We don't need to use it for life, but at least once you make a difference in their overall weight, we are seeing a difference. So any last points you want to say, madam? Any last message to the doctors who are seeing the program?
I want to say that motivation is the main thing that can is the first drug that you can give to the patients, that actually help them, understand their psychology also, how they each and every patient is different, and understanding the patient's perspective is very very important. We can't, if we can't achieve it in the one visit, our the patient can't achieve in the one visit their target. So don't get disheartened, constantly keep on motivating the patient. One day the patient will definitely achieve it. And it also sensitize the patient to sustain their weight loss that they have achieved, for the because it is a lifelong disease. Obesity is basically a lifestyle disease, and it is going to remain lifelong. So they have to attain their healthy behavior lifelong, so that the disease and its complication can be halted.
Thank you very much, Dr. Shivani, for spending time with us. And I'm
Thank
sure
you.
all of us have learned a lot. And so it has been great. Thank you, ma'am.